today we are going to talk about what's happening after the initial diagnosis. I don't have any to disclose related to this specific talk. And I just want to start my discussions like what happens, and probably you already been there, like as a family of someone who has Duchenne, or maybe as someone who actually has a dystrophinopathy. And in the initial discussion during the diagnosis, there are three main axes that we usually touch and we usually talk with the patients. One is diagnosis and counseling. The other thing is supportive care. And the third one is usually like therapies, like what's actually available. And we'll try to go through, although there's a lot to discuss during right after the diagnosis, we'll try to, in these 20-30 minutes of discussion, try to put as much information as we can. So for that, I want to start thinking about four hypothetical cases. Some of them might resemble something like you have been through. So I want to introduce you to Holland. He's a 4-year-old boy who was noticed to walk on his tiptoes by his parents since 2 years of age. He has been falling frequently, and school also has noticed that and has discussed this with the family. He was seen by the pediatrician, doctor, and he was referred to a neurologist that, of course, found a high CK and a diagnosis of dystrophinopathy. Our second case is Bob. He's a newborn with a family history of dystrophinopathy or Duchenne. He was assessed and diagnosed with a Duchenne. However, currently he's completely asymptomatic. The next person is Thiago. He's a 16-year-old boy who recently immigrated to Canada. He has been having progressive weakness since he was 6 years old, and he lost ambulation around 13 years of age. Although he and his parents consulted several times, he didn't have a clear diagnosis. And then when he arrived to Canada, he was referred to a neuromuscular specialist where he was actually diagnosed with the dystrophinopathy. And our last kid is Monica. She's a 5-year-old girl. She went to a general checkup with her pediatrician and was found to have a high liver enzymes, which is actually a blood marker. And they did a lot of testing on the liver, didn't show abnormality. She even got a liver biopsy, didn't find anything. And then after some work, someone thought, okay, these liver enzymes actually, although it's called liver enzymes, they can also come from the muscle. Someone checked the CK, and a CK is a protein inside the muscle. Then when you have a muscle breakdown, it increases in the blood, and it's quite typical in patients with Duchenne or dystrophinopathies to have elevated CK. So when it was found that, she was actually referred to a neurologist, and when it was found that she is actually a carrier, mildly symptomatic carrier of a dystrophinopathy of Duchenne. So, having presented those four cases, and maybe some of them resemble of something that you went through, I want to start beginning on something that already Penny discussed. Is like the pathway, although it's similar, it doesn't need to be the same for every patient and every family. And it's really important to understand these same stages that actually already Penny described about the grief in general, the grief cycle, the denial, the anger, the bargain, the depression, acceptance, that it doesn't mean you need to go through all these stages, and it doesn't mean that you need to go in order, and sometimes you are in one stage and you come back to the other. But one of the important things that we as a physicians or as your care team, we need to understand when we are actually disclosing the diagnosis is that we need to understand where exactly you are there. It's not the same for our 16-year-old case, for example, that has a suspicion of something going wrong with a muscle for around 10 years, than a newly diagnosed patient that the period of progression of the disease has been really short. Okay. So eventually, the process of how we actually disclose the diagnosis and how you will deal with it is completely different. So a few things that we need to understand also when there's a new diagnosis, as parents, you might find yourself that you are in two complete different stages, and that's okay. And you might have a parent that is actually in acceptance already, and another parent is actually in complete denial. And we need to help you, and this is a really important work from the care team, especially from the social worker, to try to put you sort of in the same page. and make you understand that eventually the grief is different for each person. And it's important that you go through all this together. Communication then will be a key, of course. Different individuals at the same time may want to hear different amounts of information, and this really depends on the stages. For example, we actually have cases of families that the father wanted to hear absolutely everything, but the mom didn't want to hear anything at all because she didn't believe that there was something going on with his kid. So again, it's not the wrong thing to be in different stages. So we need to help you to understand how to move forward through all these things. So eventually we can improve the care and the quality of life of your kid. It's important at the same time that we actually give hope, but not false hope. And we actually have heard this several times from the different families. Now, when we think about our different kids, and we need to start wondering, is the pathway different for each person? Well, I will say yes. And it's different because they are probably in different stages. And one of the important things that we probably will introduce you is actually the multidisciplinary care team. What is it? It's basically the multidisciplinary care brings together the expertise of professionals from a wide range of disciplines in one location to provide coordination of patient-centered care. So we know that this will actually benefit a lot. However, when we actually present multidisciplinary care, and probably you have seen this slide several times, you are introduced to this, which is a huge amount of information, a huge amount of people actually that's going to work with you. And if you see this just from the beginning, you will feel probably overwhelmed and you will feel like this. But the idea of the multidisciplinary care team is actually to move from this picture to something like this. So actually, we can actually help you to move forward different stages. Okay, so the care coordination is really important. The person who is actually going to coordinate the whole care will not introduce you to, the idea is that it doesn't introduce you to all the multidisciplinary care at the same time, because most likely you will feel overwhelmed. The initial consult after the diagnosis, you will find that in the several appointments after, you will be finding yourself asking the same question over and over, and that's okay. We are more than used to that, because we know that simulation of the information after such a shock in the diagnosis is really difficult. Okay, so we are not worried about hearing the same questions over and over. We are used to that, and it's important for us to not overwhelm you with the care that's actually needed. So again, the care of coordination needs to go in 3 different circuits. So basically, it's the patient with DMD and the family, from the physician perspective, but also from the public health perspective. If we actually refer you to everybody from right from the beginning, probably you will be waiting for an appointment for 6, 8, or 9 months or even more. So we need to understand is whoever's actually doing the care of coordination actually send you at the proper time on your life. So when we think about the families and the shock of how this the new diagnosis impact on you and your family, you will probably understand what we call the proximal impacts that will have physical, emotional, and eventually impact in your social life, and that will actually affect in your work, your sleep, your relationships, and in general in everything. Okay, so that's why it's important that we actually the initial transition from the diagnosis is we need to help you to go through that in a really slow time. So sometimes when we think the initial appointment, when we actually provide the diagnosis, most likely it's not going to be only one appointment, it's going to be several appointments until you actually transition from the first stages of diagnosis. The other important thing is why we need care of coordination. This is a nice paper was actually done some time ago, so it's probably a little outdated in terms of the prices. But this is basically the cost of care in different countries on the care of coordination for a patient with dystrophinopathy. And although there's a lot of numbers, I just want to give you the total amount. Okay, and this is in US dollars and per year, and you can see there go between 80,000 to 120. So it's important for the care of coordination and thinking about this public health system as well, is that we as people who is coordinating the care don't make you spend a lot of money sending you different appointments that it will not be useful at that point, and eventually will overload the public health system as well. And as you can see here, the early, when we divided, I mean, Dr. Dowling did this division of the early ambulatory to late ambulatory, the cost of care will actually increase over time. That's why it's important that we actually understand, the whole team, I will understand where your kid or eventually you as a patient, where you are, in which stage you are, so we actually can try to help you in the coordination of care and eventually, of course, save you time, money, and stress. Okay, so I want to start introducing you to what we call the multidisciplinary care. So usually the neuromuscular centers are actually coordinated by a neurologist or a physiatrist. In the care of Bloorview, for example, it's Laura. In the case of at SickKids, it's actually a neurologist. You will have probably respirologists as well that will actually take a look at your lungs and how you're breathing. Physical therapist is quite important, okay, just to understand where's the weakness, where's the contractures, how is it, if you have been developing scoliosis, what kind of rehabilitation you need. Do you need orthotics? You don't need orthotics. The cardiologist is really important. So we know that the patients with dystrophinopathies can actually have cardiac involvement, heart involvement, but depends on when. We don't expect that a 3-year-old will actually have a heart involvement at the beginning. Social worker, as Penny gave an excellent talk, so you will understand what's the importance of the social worker, and especially in these stages. It's quite important for the support that you need. Clinical coordinators are also essential. Probably they're going to be one of your first contacts, or the most, like if you need something, you will go to these people that usually are nurse practitioners, genetic counselors, and they will actually coordinate the care throughout the different disciplines. Occupational therapists will provide you strategies and tools to help people accomplish the daily activities. It's quite essential. And orthopedics, this especially will help you in the need of some kind of intervention, like if you have any scoliosis and you need surgery, for example, they are going to be involved. But it doesn't mean that all of these will be involved at the beginning. Okay, and of course, always the patients and eventually their families in the center. As you can see, this is actually one of the summaries of what Dr. Dowling actually showed you at the beginning, when we actually divided in what we call a diagnosis: early ambulatory, late ambulatory, early non-ambulatory, and late not ambulatory. And you can see that eventually different specialties, I'm not going to go through all of them, but the different specialties will actually have different activities depending on the different stages. So if we think about our 4 kids that I introduced you at the beginning, you will see that, for example, they actually will be at different stages when we actually do the assessments, okay? And that's actually quite important. Why? Because, for example, for Bob, that was newly diagnosed and is completely asymptomatic, most likely what I'm going to do as a care coordinator is just to monitor him at the beginning. I'm not going to start him on steroids. I'm just going to see how he's doing. I'm going probably to check on mom if she's a carrier, and probably send her to the cardiologist just to see, because remember, the carriers, moms can actually have a cardiac involvement, so we always need to check. And I will check probably at the beginning just the vitamin D, calcium, the intake, and we just monitor how he's doing over time. But it's going to be different for Ahmed, for example, who will do probably a baseline assessment and see how he's doing. Is he walking on his tippy toes already? Does he need orthotics or braces? Discuss the start of steroids. Remember, for Duchenne patients, we usually start steroids around 4 to 5 years of age. And for Baker patients that are actually a milder clinical picture, we might not even start, depending how the patient is actually doing. Sleep studies, we can do actually a baseline assessment, but they are a low risk. So we might do a referral to respirologists or eventually just a sleep study at the beginning, and we just follow you and see how do you, and we do it like a year assessment. The same thing for cardiac assessment. We might send you to the cardiologist, or in some centers, they will send you to a cardiologist. Sometimes centers will actually do the electrocardiogram or echocardiogram at the beginning, and will not send you to a cardiologist maybe until you're like 6 or around 7 years old, when you actually are more worried about having a cardiomyopathy. You remember that usually we would start eventually medications that will change that will help stop the remodulation of the heart. By the age of 10, they should actually get that kind of medication. From the bone health perspective, we need to be sure that it has vitamin D, calcium intake, yearly bone health, especially if the kid is actually in steroids. If the kid is not under steroids, then we don't worry so much about that. And of course, always know the social part, the patient and family support in all the stages, all the time. For Monica, in this case, like she basically has high CK, but there's no weakness. So we just monitor her, and of course we check for the cardiac. We don't expect that the female carriers will develop any cardiomyopathy until around 20 years of age. However, we usually check frequently, maybe once at the beginning, probably at 4 years of age, once every 2 years, and then starting 7 years of age, we might start doing every year. Now, for Tiago, who is actually the most symptomatic and more advanced case, in the one we actually discussed, probably we'll need to discuss if we need to start steroids or not. We might think, some centers, we think that it might be too late. Oh, sorry. I have my kids running around me. I'm sorry about that. So we might decide not to start steroids at all, depending on how he's doing. If he's too advanced, we might not start, or eventually we might start with a eventually lower dose. We need to be sure that he completes vaccination. We need to refer to respirology. We need to do a sleep study. We need to refer to the cardiologist right away. This one can't wait. He's a higher risk of having a cardiac involvement. We need to send him to PT, OT. We need to think about if he has scoliosis. Is he under risk of worsening? Is he even a person who might benefit from a scoliosis surgery? And also, when he's 16, we need to start preparing him for adulthood. The transition to become a more responsible person is part of it is actually being responsible on his own health. So as you can see, the stages of each patient, of each kid is completely different, and the pathways is going to be different. Now, the third axis, and this is really short because I'm not going to discuss new therapies with you today, but I just want to mention something. In the initial assessment, a lot of the families will just ask it right away if there is anything that we actually provide a new therapy, clinical trials. And I think it's really important that we actually find a cure or eventually medications that will change the natural course of the disease. It's extremely important that. But I just want to mention that it's as important to support the research on finding these medications or finding the cure is as important to actually that you support your care team. You are part of the working team. We need to know what is the things that you think it's going to be best for your child. Okay, and that's actually quite important. I just want to show you just an example. This is a complete different neuromuscular disorder, but it still is involvement of the muscle. But I just want to explain you what I'm trying to show you with this. So infantile onset of on-pump is, again, another genetic disease that actually is missing an enzyme, so it doesn't actually produce the energy that needs to happen. And usually the kids with infantile onset will have a cardiac involvement, and they will be really floppy, really weak, and usually they die by 2 years of age. In 2006, there was an approval for enzyme replacement. So basically you are replacing this protein Okay, again, and everybody thought, okay, this is fantastic. This is basically the cure. But we know that in 2012, there was starting with the care teams starting to report what we call the new clinical pictures of kids that actually have survived these first 2 years of life. And now they're living longer. And now we're finding new issues, new problems, new things. So it's not that I want to break any hope here at all, but I just want to emphasize the importance that your care team needs to understand how these new therapies are going to change the natural course of the disease. This is extremely important. So again, understanding how an intervention may impact the natural course of the disease is as important as finding a therapy. So this is my final comments. The importance of meeting your core care team is really important. A new diagnosis may impact in your family dynamics, okay, as I mentioned, and you need to understand that this is something that it will impact in the family in such way that it might generate huge problems, okay, and it's not uncommon. You're not alone in this. We'll help you go through that. Coordination care is extremely important, and supporting your clinical care teams is extremely important to provide better care for you and your family. So with that, I just want to finish here, and I know we'll pass over to Christine, and I'll just stop sharing, and Penny.
Can you see that slideshow? Is that okay? Okay. So thank you so much, Dr. Gonorowski. I think you've covered a majority of things, so we'll go through ours, but I think some of it you've already covered. We really just so Kristen and I just wanted to touch base briefly from our perspective at Holland Bloorview, a little bit about the impact of Duchenne on the family, coping with a new diagnosis, and some of the medical and physical considerations and school supports that we might look at when a child is newly diagnosed, just from our experience in working with families in the neuromuscular clinic at Holland Bloorview. So again, I know you've already kind of seen a slide with some of the different clinicians that you might encounter. So just as Dr. Gonorowski said, you'll probably encounter a variety of different clinicians. And not all clinicians will see every child when they come to clinic. But I just want to highlight again the importance of the multidisciplinary team can really help to monitor and bring in the supports when they're needed, which can also help to decrease the number of appointments, for example, that you might need to have. So in our clinic, we really try to do a complete assessment and develop a plan with the child and family to reach their goals. So we might talk about treatment choices, equipment, other specialists, and community resources, and develop a plan together to make sure that the follow-up care is appropriate. I'm not going to go through each of these. I think we talked a little bit about it earlier, and we can certainly talk about it more in the Q&A if you want. Just in terms of my role on the team as a social worker, in addition to providing some of the emotional support and just sort of adjustment to the new diagnosis, there might also be some support around funding and resources if that is something that families need. Sometimes there's different funding sources that are available depending on where you live as well. So in the presentation before this one that I spent some time talking about common reactions to a new diagnosis and coping strategies. Although I do note that in my poll, it looked like there didn't seem to be anybody on that call that's identified as being in the new diagnosis stage. So I'm not going to spend too long, but just wanted to, again, this is not so different from Dr. Gonorowski's points, so I won't spend too long, but I just wanted to point out that, again, with the impact of Duchenne affects all aspects of your life. So I'm just going to highlight a few here. One would be family, so parents coping differently with the diagnosis, and siblings who sometimes might feel excluded at certain times due to the amount of focus on the child with Duchenne. The impact on friendships, so perhaps having less opportunity to socialize with friends or friends who may not understand what you're going through. It could be impact on your leisure time because you don't have the opportunity or time to do some of those things. In terms of peace, it may be difficult at times to feel peace because there's some worries or some mental health challenges such as anxiety or depression. In terms of work, some families need to stop working or take time off work or reduce their hours, and this can affect financial stability along with some possible increased expenses. So again, these stages were discussed in Dr. Gonorowski's slides, so I won't go over that too much, just the different emotions that you might experience, especially at new diagnosis. But not everybody reacts the same. I think that's the most important thing to say here. And also that, there isn't a particular order that you might feel them, or they might come and go depending on different stages of transition or changes in function that you might be experiencing. So it's completely normal to have these emotions. It can be very challenging and important to get that support, but know that there's also going to be many moments of happiness and joy as well. And lastly, just from my perspective, just around coping with a new diagnosis, just some of the strategies that I had suggested in the previous presentation. So, just taking time to learn about DMD, but going at your own pace. Sharing information with family and friends, just so that you can feel less isolated and more supported. And that will help you to set up your support team. Continue to nurture close relationships. So keeping that communication open and honest, listening to one another, trying to carve out some dedicated time with siblings if you can. Give yourself a break, even if it's just for a few minutes, to do something you enjoy or to have a laugh or to do a hobby that you enjoy. Practicing some self-care, whether it's meditation, relaxation, mindfulness, and lastly, asking for help. So this could be speaking up to family and friends about a specific need, or getting emotional support. So it's just important to remember that if you are struggling with mental health difficulties, it's really important to get support, whether it's counseling, therapy. Ask your team for suggestions if you're not sure where to access the support. So I'm going to keep my slideshow up, but I'm going to pass it over to Kristen now.
Perfect, thank you. As Dr. Gonorowski has mentioned, your physician will review the advantages and disadvantages of steroid treatment and when to begin. This is typically part of the initial discussions. If families wish to proceed, we arrange to check for MMR and varicella titer levels. It is extremely important that everyone stays up to date with routine recommended vaccinations, but it is not recommended to have live vaccines once steroids are started, as your child might get the infection the vaccine is meant to prevent. Once titer levels are reactive, steroids can be started. So for example, now that it is flu season, we would recommend opting for the injection form rather than the nasal spray, which has the live vaccine. If families agree to start deflazacort, we will fill out the application through the Special Access Program to request the medication. I'm happy to discuss this further, or you can ask your team as processes may be different. Next slide, Penny. With the first visit, we typically provide education on important medical considerations. Next slide. We recommend an emergency alert to help identify succinylcholine, and inhaled anesthetics should be avoided. Succinylcholine is a muscle relaxant used typically by paramedics in emergency situations to help provide an emergency airway. Inhaled anesthetics are used for sedation, typically for surgeries. Alternative medications will be used instead, and this is important to let the school know in case paramedics arrive before parents. Next slide. Wallet cards are also very useful and can be easily distributed. If you visit the PPMD website, you can place an order, and the wallet card provides a general overview of emergency information for those with DMD. Muscular Dystrophy UK alert cards also provide a general overview of the care required for monitoring those with DMD and emergency information. It does, however, have UK contact information, so you can disregard that, but we do find that the content is informative, and it also comes in a PDF format so that you can print as many as you'd like, distribute them, and keep them in your wallet. Next slide. With the overwhelming amount of information, we have developed handouts on 3 key medical safety information. This is at Holland Bloorview, and we put it together as an emergency package. We recommend a package for the home and a package for the school. PPMD also has great resources that can be printed off their website and used for an emergency package. Some medical professionals in your local community may not be familiar with DMD, and it can be difficult for families to explain this information. So these handouts help guide them in case of an emergency. If your child is on steroid, please ask your team about the specific stress dosing, as it depends on the routine dose your child may be on. Next slide. And we also review general health recommendations quite early on. As Dr. Gonorowski mentioned, for those taking steroids, it is important to have good calcium intake because steroids can decrease bone density, making them thinner and more at risk for fractures. We also recommend vitamin D 1,000 units daily to help with calcium absorption. Another side effect of steroid therapy is increased appetite. And so we try and have healthy weight and eating conversations right from the beginning so that it is easier to maintain. We have also been recognizing that in DMD and while taking steroids, cholesterol and triglyceride levels seem to be on the higher end of normal. We can't quite figure out the mechanism exactly yet, but we are seeing this trend. And so this is another important reason why our team tries to talk about healthy eating habits very early on, along with annual blood work to monitor. Next slide. During the initial visits at Holland Bloorview, our physiotherapists and occupational therapists will also review activities and energy conservation. Sorry, I'm trying to flip mine. There we go. We encourage age and energy level appropriate activities as every body is different. The child can usually make good choices and limit their activities when needed, but we may need to encourage these breaks, especially when they are doing something fun like playing in the playground or if they're at parties. So how do we know what the right amount is? If your child is experiencing weakness after 30 minutes of activity, soreness 24 to 48 hours after activity, or having muscle cramping or pain, then likely that activity was too much for them, but you will learn what the right amount is and when you need to encourage a break. And you can also talk to your team about this for more ideas. Exercises should be submaximal and not feel effortful. And the key message here is that we want to encourage activity and play, but we also need to find the right balance. All this information is overwhelming, and to be able to articulate it and share it with the school can be daunting. At Holland Bloorview, we provide a school letter and participate in school meetings to help review our recommendations and medical safety. So please speak to your team to help navigate your system. And some really nice school supports can be found on Muscular Dystrophy Canada. They can help coordinate someone to actually come into the school or your communities to speak to you about Duchenne. They also have a comprehensive school resource guide called under Muscle Facts there. And Parent Project Muscular Dystrophy also has educational resources for early childhood, late childhood, early adolescent, late adolescent, and adulthood. And this link here takes you to the early childhood resources. As Dr. Gonorowski and Penny has mentioned, your care team is very important and we are here to support you.